Magnesium is crucial for over 300 processes in your body, from energy production and muscle recovery to sleep quality and stress response. Yet most Americans don't get enough. In fact, in a peer-reviewed clinical trial published in the Journal of the American College of Nutrition, more than 75% of participants showed suboptimal magnesium levels before the study even began. Those who took Jigsaw Mag SRT, a time-release magnesium malate tablet, saw magnesium rise 30% over 90 days, and deficiency symptoms dropped by 63%. Remarkable results backed by real science. And for sleep and recovery, Jigsaw Mag Soothes delivers. In a 4-week clinical trial tracked with Oura Ring data, participants saw a 17% improvement in sleep quality, felt 34% less stressed, and rated their satisfaction 85 out of 100. 82% said they'd buy it again. 2 supplements, 2 clinical trials, 1 company that does the research. Jigsaw Health. Mag SRT for daily magnesium replenishment. Mag Soothes for calm, restorative sleep. To order, go to jigsawhealth.com. That's jigsawhealth.com. Use coupon code Hoffman15 for 15% off your order. That's jigsawhealth.com, code Hoffman15. Welcome back to today's Intelligent Medicine Podcast. I'm your host, Dr. Ronald Hoffman. An important podcast because, it may be a matter of life and death. Because when you go to the hospital, you got to keep your wits about you, and it's hard to keep your wits about you if you're sick. So perhaps you could use a patient advocate to come with you. At the very least, you can research what's about to befall you in the hospital if you're going to have an elective procedure. And that's the message of today's guest, Dr. Julie Siemers, author of Surviving Your Hospital Stay, a Nurse Educator's Guide to Staying Safe and Living to Tell About It. So, Dr. Julie, what are some of the high-risk medications that we need to be thinking about? When you're on these medications, maybe a little higher level of vigilance.
Definitely. Blood pressure medications, heart medications, such as if you've got some dysrhythmia or an irregular heartbeat, pain medications, as we're pretty much all aware about. But there's some things that go along with some of these medications. Blood thinners, of course, we talked about a little bit about that one. But let's just take opioids or pain medications, for example. I just wrote a little social media post about this not too long ago about the combination of opioids with obstructive sleep apnea. Now, a lot of patients don't even know they have sleep apnea. And it really is,
pretty prevalent.
It is not a sleeping problem, it's a breathing problem where they quit breathing for seconds, sometimes long periods of time in a minute. And you combine that with a pain medication that can cause respiratory depression or slowing of the respiratory rate. And that's a lethal combination there, or it can be. So it's just learning.
Yeah. So how do you avoid the pitfalls of that? You do a good assessment of whether a patient is likely to have it, or if they have a history of it, or if they have like a big, collar size, neck size, if they're obese. That's something to look out for.
And if you've got a partner that, snores and then you don't hear them breathe for a little bit.
Ask the question.
Yes.
Ask the question. Yes. And because a lot of people are unaware of it. And it's then you turn to the spouse and say, does he or she snore? And they go, boy, do they snore. And then you're like, okay, bingo. And then you do, proper assessment for OSA, for obstructive sleep apnea, sleep study, and bingo, you got it. And man, these people already have alarming pauses in their breathing that can last for many seconds. And you put a little bit of an opioid on top of that, and big trouble. That's one of the sources of problems. You say in the book that there's a crisis in nursing. I could think of a lot of ways that there could be a crisis just in terms of the, manpower or woman power. But what were you alluding to? It was like a burnout crisis or a morale crisis or what?
It's multifactorial, unfortunately. We don't have enough nurses. The experienced nurses are either leaving the profession as they did after COVID, or they're set to retire here soon. They're the ones that have been, years in the profession. Nurses aren't staying in the profession like they used to. I think the latest
Why?
Um,
Why?
it is so complex. A lot of hospitals, when they cut their budget because their operating margins are so small, the workforce is the largest part of their budget. And so they'll, cut the staffing. And so instead of having 6 patients to take care of, you may have 8, and
Okay.
that's really concerning. But
Hmm.
the other,
It's like
right,
speeding up the assembly line,
exactly. And that's when
almost. Yeah.
mistakes happen, right? The other part of it too is that nurses, there's 3 studies that came out, one 2006, one in 2016, and then one just recently in 2021 that took all 3 studies were designed the same. Over 5,000 newly graduated nurses that passed their boards and got their license, and did a 5-hour exam to check not just written knowledge, but the application of knowledge. How would you manage this patient like in a simulation lab? And the practice readiness and safety and clinical judgment fell that from 2006, 35% were deemed safe, competent, and practice ready. It fell to 23% in 2016, a decade later. And then in 2021, it fell to 9%. Yeah,
Wow.
it's
That's
very
concerning. And what's the reason for that, do you think?
well. I know that they did that study in 2021 to follow up and say, hey, did remote learning, like we had to do during COVID,
Hmm. Yeah.
impact? And yes, it
Hmm.
absolutely did. In
Hmm.
fact, in 2024, ECRI, a nonprofit organization, puts out a top 10 patient safety concerns every year. And in 2024, it
Hmm.
was practitioners not ready for practice and not safe. So not just nurses, but healthcare. Yeah, I mean
Yeah.
that's huge.
Is it because of the shortage that they're pushing people through the pipeline who may not be adequately
Well,
prepared or
that and
qualified?
they weren't getting the hands-on. I'm sorry, but you can't learn to do an assessment
Hmm.
on a teddy bear over a video, right? So they missed and
Got
they
it.
didn't
Got
get
it. Got
clinical
it.
time. The boards of nursing, that's what I can speak to because I know boards of nursing made allowances because they didn't want us not to be able to graduate nurses because we still need them. But many nurses
Yeah.
graduating during that time did not have hands-on clinical. And it depends on some hospitals don't have a transition to practice program, and you got thrown in with a preceptor or a mentor,
Yeah.
and you
Yeah.
put on your rollerblades and you do your best.
Wow. Uh, One of the issues that you point to in your book, and I really I can understand this issue because even when I was doing my hospital practice decades ago, there were all kinds of gadgets designed to monitor patients, and it's actually psychology experiments show this is that if you have a threshold for alarms that occur too often, people just tune out on the alarms, and they sometimes actually turn off the alarms because it's just annoying. I mean, the sounds in, as you know, in an intensive care unit are really, it's a clamor and it's disconcerting to the practitioners, but certainly to the patients who are trying to recover. The fluorescent lights are on all the time and the noise levels. And so people turn off alarms.
Yep.
What's the
Well,
downside there?
there's a couple stories in my book where that occurred. A 16-year-old girl had a tonsillectomy. And again, the optimism bias that occurs.
Quote,
Yep.
routine
Yep.
procedure.
And when they
Yeah.
don't have any comorbidities, or any other illnesses or
Hmm.
whatever, then they're not watched very closely. And her alarms were going off, and it was a busy PACU, post anesthesia care unit. And they turned off her alarms. And when they did find her not breathing, it was too late. The resuscitation was ineffective. It's just, that optimism bias again when, oh, well, they just had surgery. Surgery went fine, and they're not watched very closely
Hmm.
is a big, big problem.
So when you discuss error, a big theme is what you just said,
Hmm.
bias. There's optimism bias. Maybe you can explain it. There's confirmation bias, which is kind of groupthink that leads you to believe it's going down one track, like the patient has the flu. Well, no, it kind of looks like the flu, but it could be something much more dire. That's how mistakes get made. Can you talk a little, I know I think there's several dozen biases if you really break it down. But can you talk about the common biases that can lead to medical errors? And, maybe that's where a patient can step up and say, hey, I know you're going down this track here with my aunt, my brother, my sister, my child, but are you sure that's the right
Yeah,
path?
I'll give you the example of the story that I opened my book with, and I actually talked about Lewis Blackman in my TEDx talk too, because his case to me is so heartbreaking. I'm a mother of seven children, so that he was a 15-year-old boy. I mean, I really relate to, I can't even imagine the loss of a child, let alone to medical error. But Lewis had surgery for pectus excavatum, not a life-threatening emergency, but
That's just a
mhm,
depression in the chest. So it's more of cosmetically to protect it, but also it may impinge a little
right.
on the breathing. So it's just to bring out the chest wall a little bit. It's not like it's a serious surgery, but it's not like a heart
Right.
transplant or something very
Yeah.
dicey. Yeah.
So he came through the surgery just fine. They gave him an NSAID, Toradol or Ketorolac is the other name for it after surgery. The following day, he's got abdominal pain, and his mom's like, what's going on? That seems weird. He had chest surgery. Then the following day, he's still having abdominal pain. The nurses are said, it's probably just gas pain. Get up and walk. The resident said, maybe he's got a bowel
hmm
obstruction.
That's an example of
Exactly.
optimism bias. In other words, it's routine. We see
Yeah.
that all the time. It's
Yeah.
probably nothing.
And his
Yeah.
belly
Mhm.
starts distending a little bit, and now his hands and feet are cold, and they still are not tuning in to this is something serious. His heart rate got up to 126. He had no urine output for 24 hours. Midnight, his heart rate's 147, which is double.
We're talking septic shock here. It sounds
Well,
like,
and
right?
he's got this distending belly. And the next morning, he
hmm
cardiac arrests and they can't revive him. And
hmm
on autopsy, they found 3 liters of blood in his abdomen.
Okay, so he had an
Yeah, he did.
internal
He ended
hemorrhage.
up
Yeah.
with, from the medication, all this time he's having pain for 3 days, and now he's got a duodenal ulcer. Yeah,
Which is a medication that actually, can
yeah,
actually cause a
yeah,
stomach
exactly.
perforation.
So,
Yeah, yeah, yeah. Very, very disastrous mistake. Confirmation bias is a little bit like, okay, here's what we think. It's, let's put blinders on. We're going to go down this path and we're not going to consider other
yeah.
possibilities. Let's open the lens a little bit and think about what are some of the potential alternative diagnoses. That's important to be thinking about. So these are some of the ways that we can address preventable medical errors. Um, okay, so I've been in the hospital a couple of times. I'm a healthy guy, but I'm a little bit of I don't know, uh, uh, a risk taker. And during my career as a triathlete, I broke my leg, and in the hospital, I was in the hospital. They, had to put in a metal rod, and it's kind of a big deal, but nothing that was exceptional. Kind of routine procedure for them in the hospital, at hospital for special surgery. And my relatives asked, would you like a private duty nurse to help you? And I said, well, why do I need a private duty nurse? There's great nurses here. But unbeknownst to me, they hired a private duty nurse for me. And this is advice that I've heard is that if you're going to a busy hospital, the nursing, fine. The nurses are, they're okay. But to have that extra measure of care privately, and you're not going to often get this paid for by insurance, hire, if you have the means, a private duty nurse who can literally hover at your bedside and intervene for you. Is that a thing? Is that a thing that
Yes,
makes
if you
sense?
can. If not, then make sure you have a family member with you or a loved one that can, as you said, hover over you and just make sure. Ask those questions. What medication are you giving? How about the heart rate? I've noticed it's been elevated for, you know, an hour now. That's not a normal range, is it? Can you help me understand what may be going on? And yes,
Hmm.
just advocate for you in all of those ways.
What provisions do hospitals make to accommodate relatives, family members, advocates being there, because there's certain visiting hours, and sometimes you can sit in the room. I've even heard situations where you can get a cot and you can sleep in the room. What's the
It
deal?
really depends on hospital policy. I mean, when I worked in the ICU, we had really strict, family member can come in for 10 minutes every hour or, 3 times a day or something. And I think it just depends on the facility, but I would certainly still advocate as much as you can during those visit times that you can. Ask for lab results, ask for diagnostic results. That's another big area of opportunity to help, so that those things don't fall through the cracks. Because there have been, I think one of the stories in my book is about a pathology report that got misfiled somewhere and the family didn't hear
You
back.
know?
And so they assumed the biopsy was not cancerous when in actuality it was. And
Mm,
so that's another
hmm
proactive thing as a patient or family member that you can do, is make sure you get your lab results, your pathology reports, your diagnostic.
And now that's
Yeah,
more accessible now. It used to not be accessible, but most states, I think it's a state by state thing, you have the right to
yeah,
your lab tests. Now, this can result in a lot of confusion because, they say this is high, that's low, and you don't know how to interpret that. But it's worth calling that to the attention of a doctor. And often a doctor may say, look, this is not what you're seeing, in my experience, is not a
right.
dire sign. It looks dire because this is high, that's low. Everything is like, as a layperson, it freaks you out to see those
Yeah, for
aberrations.
sure. But again, you're just being inquisitive and making sure that those results get looked at and that you can get them interpreted by your physician.
Okay, folks, at this point, let's pause and allow one of our sponsors an opportunity to share an important message with you. So here goes. Listen up.
Are you ready to experience the future of digestive wellness with Dr. Ohhira's new and revolutionary postbiotic fermented food concentrate? Capsule-free and in individual sachet packets that harness the power of 5 years of fermentation and over 500 concentrated bioactive postbiotics. Dr. Ohhira's postbiotic fermented food concentrate is a nutrient-dense paste designed to supercharge your digestive health, aid in nutrient absorption, and support whole body immune wellness. Each sachet packet delivers a potent blend of fermented paste and prebiotics which serve as fuel for your body's own unique gut microbiome. This concentrate supports your entire digestive tract, does not need refrigeration, non-GMO, dairy, and gluten-free. Dr. Ohhira's postbiotic fermented food concentrate. It is the ultimate embodiment of traditional Japanese fermented craftsmanship, designed for those who seek the highest concentration of nature's restorative power in every serving. Ask your natural products retailer for it today or online at essentialformulas.com.
Thanks very much for listening, and thanks for supporting our sponsors. They, of course, are what make intelligent medicine a continuing free resource to you. And now back to today's guest, Dr. Julie Siemers. So I've heard that there is even a place for asking, if possible, for a room where you're not sharing the room with a patient who has a potentially infectious disease, or a room, here's a simple measure, a room with a window where you can get some sunlight. That can actually make a
Yes,
difference in terms of the outcome for
yes,
patients. Now, can you advocate for that? I mean, look, often it's not practical to do that because you're lucky to get a
right.
bed. There's a fight for hospital beds. Even doctors can't get beds for their patients when their patients languish in the emergency room sometimes. But if you have the option, is that something that you
Well,
can
you
advocate
certainly can
for?
ask for the window bed for sure. But I would say if there is a patient in the same room that has an infectious disease, they should not be sharing a room with anyone. I mean, that's still healthcare acquired infections are still a really big problem that impact and kill many patients every year. And so the hand washing, that's
Hmm.
another thing I talk about in the book that you should
Yep.
ask people, anyone that comes into the room, coming over there to touch your mother, father, husband, whatever, is please wash your hands. And sometimes they'll say, well, I just did. Well, I still want to see it, as a patient advocate,
Hmm.
because that is the number one way that we can eradicate or help diminish healthcare acquired infections for sure.
Indeed. Because I have a recollection of the other time I was in the hospital. I had a routine tonsillectomy, and so I don't know. They probably this is how they figure things out in the hospital. They take an 11-year-old child and they put him in the room with a dying cancer patient who is has some gangrenous wounds that are foul smelling, and that was my
Oh man.
hospital experience. And maybe that shouldn't have been my introduction to Hospital 101.
That's terrible.
Probably not. But aside from the minor trauma that may have inflicted on my psyche, I emerged unscathed. So infection control is another thing, and this is actually, you can look at hospital ratings for
Yes.
that, and there's certainly issues related to infection control and hygiene, and some of these things. So you also have a website which is called LifeBeat Solutions. What are you offer courses to health professionals, I guess primarily nurses, via that website. What are some of the courses that you offer to health professionals there?
The two I started out with and built on were the failure to rescue, because it is not taught in any health.
Which is actually so important that it has its own
Yes.
acronym,
Yes.
FTR, failure to
Yes.
rescue. That's a
Yes.
thing. So how is that distinct from other previous concept of malpractice or error? FTR.
It started in the literature
It's-
probably 25 years ago, and it started with surgical patients failing to recognize when a postoperative patient was starting to deteriorate. But it's just as impactful, and maybe more so, with medical patients who have the same physiological display of beginning to become clinically unstable. And so if it's not taught
Okay.
in nursing curriculum or any other healthcare profession curriculum, I think that's a huge gap in opportunity where we can cluster those signs and symptoms, and they're all physiological, of how can the nurses tune in to catch a patient deteriorating before they get moved to the ICU or go into cardiac arrest. I think that's a huge opportunity. And then the 8 courses that follow that are, what are those pillars of harm prevention? Neurological assessments, go into the physiology and the pathophysiology of vital signs. What does it mean when the heart rate's picking up?
Now, these are all RNs who've earned the
Right.
RN degree. And so this is like postgraduate training for them to accentuate their skills and fill in the gaps that their original training may have not emphasized as much.
Nursing school, the bachelor's in nursing is the second hardest bachelor's degree in the country. First is engineering, and then is a bachelor's in nursing.
Yeah, and
Right.
people underestimate that. And I've talked to nursing students, and some of them are very intelligent women, a little bit like you. They've started maybe a little bit in the field of nursing. They have their families, and they go back, and they go, it's so hard. It's so hard because they feel rusty in terms of their academic skills. There's a lot of memorization, tests. It's challenging.
It is. Yeah. And we
Not
take
easy.
that 4-year degree, and most schools out there, including the one I'm at, is a 3-year program. And so it's very accelerated. When I have a patient that has to come, a student that has to come to my office because of academic integrity, they cheated on a test or whatever. And there's a lot of that nowadays because they're working parents and they're, trying to get through school, and they don't understand the gravity.
Cutting
Exactly.
corners.
And when I explain to them, if I were running a school for the arts, I could care less if you cheat, because you don't have a patient's life in your hands. But if you're cutting corners, as you said, on learning, what does it actually mean? What is the clinical judgment behind, wow, baseline heart rate is not the same as it was a few hours ago, or the respiratory rate is increased, or no urine output, or any of those physiological signs. I think it's of grave importance to re-educate or educate sometimes in those missed concepts of connecting the dots to really say what's going on with this patient.
So there's a whole other aspect to nursing these days. We're talking about hospitals. But a lot of nursing occurs out of hospitals because we now have VNs, visiting nurses, and that's a cool thing because it decentralizes care. In fact, other countries really leverage visiting nurses a lot more than we do because we do a lot of care in hospitals. Some of it may have to do with reimbursement because maybe you get more money because when you treat a person in hospital than out of hospital. But it actually makes more sense to care for people in a decentralized fashion at home where they're comfortable. But somebody medical needs to keep an eye on them. So, there are these visiting nurses who are traveling around. They've got an itinerary of patients they need to visit. Any special advice in dealing with a VN, a visiting nurse?
I think the more that you can learn from them, if you're a family member, asking, what do I watch for? What are the signs of infection? Could mom just had hip surgery? Or when is it actually an emergency that I should call if, dad breathing is looking labored? What should I watch for? What should I do? And just learn from them. They usually will come in and do some tasks like a dressing change or an IV antibiotic in a PICC line or something, but just,
Maybe they can teach you to outsource certain simple tasks like changing a dressing or inspecting the body for decubitus ulcers or things like that you can actually impart to a relatively competent adult who's supervising a patient, right? So take the opportunity to learn from nurses and leverage that and become a care partner with nurses and develop a relationship if possible. Because with a visiting nurse, it's actually more feasible because hospital stays are very short generally. But a visiting nurse, you can develop a sort of a long-term relationship with them, and they're great. And they're great even in extreme circumstances like hospice care. That's a special instance where, my goodness, visiting nurses are like angels of mercy in circumstances like that. They're skilled, they're tactful, they're psychologically astute, and they perform a very, very important function at end of life.
My first job out of nursing school years ago was on the oncology floor, and wow, I have so much respect for those oncology physicians and the nurses that do end of life care. It is not easy emotionally at all. But some of those patients are the ones that I remember the most from years ago because what they're going through is so raw. I remember a 40-year-old patient dying of breast cancer, and she said, who's going to take care of my 16-year-old son? We have nobody. Just heart-wrenching. But again, it's a way that we can connect with humanity and really give that compassion.
So as you see, these rapid changes overtaking the American healthcare system, some of it top down, but some of it also driven by technology. What do you envision for the nursing profession? And, you certainly have a role in enhancing nurses' skills and educating the public about how to leverage the skill of nurses.
There's a lot of talk about AI, as you would imagine, and I think there's a lot of opportunity with AI. I know some people are scared of it because they don't really understand it. I was just at the Institute for Healthcare Improvement's Patient Safety Congress in San Diego last week, and there was a wonderful talk from a doctor out of UCSD who's done a lot of research on how helpful AI can be. We know that there's a radiologist shortage coming up. And I think there's opportunity for nurses in the fact that documentation takes so much time. They're away from the bedside. And if we can get AI to help with that, whether they wear a recorder and it goes straight to the patient's chart, I just did a dressing change and they narrate, kind of like doctors when they give their, exactly.
A dictation.
Yeah.
Post-operative dictation, where they're just, that whole thing. But also, is there a potential for AI to help to increase awareness of patient distress? Because with all the data that comes off of a patient, sometimes the human mind has difficulty discerning patterns. And perhaps AI can be harnessed to say, this combination of data suggests that we're going into the yellow zone, perhaps towards the red zone in terms of a patient's status. And, of course, it requires a human to have the judgment to either accept or overrule the impressions, essentially, of a machine. But is there the potential for AI to improve the efficiency of nursing staff at the bedside? I think that's where some of the revolutions can occur.
They have early warning systems in hospital. Not all of them, but some of them. And again, that's as good as the data that's entered. For example, we know that nurses don't count respiratory rate as they should. And it's the earliest and most sensitive indicator of patient deterioration. And so if a nurse puts in the system, respiratory rate of 16 instead of actually it's 22 or 24, then that is a miss. So again,
and that could happen just because the nurse is in a hurry, and it's like, it's been 16, it's been 16. It's like, hurry up, punch it in, boom.
Exactly.
Right.
But that again is the system would work better if the data was accurate. And then you wouldn't have, like we talked about before, the alarm fatigue. You would also get early warning system fatigue if you get alerts that really aren't either way, that are not telling you when something really is wrong with the patient or over, crying wolf or whatever.
Yeah. And that's the dilemma. That's the dilemma with all these automated systems. Once again, it boils down to skilled nursing care, and that's something that you're advocating for, but also you're advocating for public awareness. And, hospitals can be a dangerous place, surviving your hospital stay. Your book is a great resource. People can get it from the usual sources, and for health professionals, Life Beat Solutions, it has a lot of resources for advanced training. So, the message I think to patients is speak up and don't give up.
Yes.
Right?
And along those lines, understanding that there's a chain of command in the hospital is really helpful. Learn to speak up and use the cuss words: concerned, uncomfortable, scared, and a safety situation. And if you're not getting action, then escalate up to the charge nurse, the house supervisor, the administrator on call even. And so that's the part about the 3 Ps of being persistent. So again, advocating for your loved one honestly could make the difference in the outcomes.
And a change in health professionals' attitudes would be helpful too, because this will only help them to avoid errors which are can be prohibitively expensive and damaging to an institution. So, take that under advisement. When a cranky patient tells you about something, you might take umbrage at it, but it might also end up saving a life and saving your institution a lot of trouble.
Amen.
Right? Good stuff. All right. Thank you, Dr. Julie Siemers. I'll spell it out. It's Siemers. Thanks very much for joining us, and keep up the great work as advocating for patient safety.
Thank you. I appreciate you having me on as a guest and sharing hopefully some helpful information.
And by the way, you've got a website at drjulie, Julie, Siemers, Siemers, drjuliesiemers.com. That's your personal website. Thank you so much. I'm Dr. Ronald Hoffman, and this is the Intelligent Medicine Podcast. I want to thank you for listening to the Intelligent Medicine Podcast. Follow us on Apple Podcasts, Spotify, Amazon Music, or your favorite podcast app, and get new episodes automatically downloaded every weekday. And please give us a rating and review. It truly helps new people discover intelligent medicine. The Intelligent Medicine Podcast is for general informational purposes only and does not constitute the practice of medicine, nursing, or other professional healthcare services, including the giving of medical advice, and no doctor-patient relationship is formed. The use of information on this podcast or materials linked from this podcast is at the user's own risk. The content of this podcast is not intended to be a substitute for professional medical advice, diagnosis, or treatment. Users should not disregard or delay in obtaining medical advice for any medical condition they may have, and should seek the assistance of their healthcare professionals for any such conditions. Finally, please visit drhoffman.com and discover everything Intelligent Medicine has to offer, including frequently updated, unbiased health news, and fully vetted product and supplement recommendations. There were many important reasons why I started my FullScript online supplement dispensary. I wanted to offer you the same curated professional-grade supplement brands that I use, the ones I know and trust. I also wanted to ensure that they weren't counterfeit or expired. Recently, I've been hearing more and more about counterfeit or expired products purchased from online retailers. With FullScript, you can be confident your supplements are genuine and they'll arrive with optimal freshness and potency. Also, buying through FullScript offers fast, free shipping, optional refill reminders, and a highly rated mobile app. It's safe, secure, HIPAA compliant, and offers world-class support. Go to drhoffmanstore.com for more information and to start your free FullScript account. You'll get access to the supplements and features you need to help you achieve your wellness goals, including my custom targeted protocols that combine the products I recommend to address specific needs: heart health, immune support, and much more. To get started, just go to drhoffmanstore.com, drhoffmanstore.com.